going to talk about now, let's see, microcirculation and lymphatic physiology. All right, so, non-disclosures, and I believe this is 20-minute talk, but that's fine. We'll go that way. When you're a hammer, everything looks like a nail. When you're a vascular surgeon, everybody's going to be do vascular surgery here, right? Yeah, okay. So when you are a hammer, everything looks like a nail. So you want to hammer everything, even if it doesn't need to be hammered. So be careful, because you might get in trouble. Brief history, really, really brief history. Chinese, yin and yang, all the way to DeBakey, perfusion, microcirculation. So it has gone through a lot of changes, a lot of discoveries that have permitted stop the heart and do surgery, something that was absolutely impossible in the past, and I'm a witness of that. You know, Dr. Reardon, I don't know if you know Michael Reardon, he did an AVR on me 10 years ago, and I'm here. So I'm a believer that we are looking for miracles every day. When your heart stops 2 hours, and I'm here talking to you, I don't think that is anything short than a miracle, but we don't see it because we are expecting people walking on water and making water into wine, and miracles are every day, and we need to be aware of them. And this is one of them. The microcirculation is a very complex concept that you need to start learning, because it's where the future of vascular surgery is going. I am a vascular surgeon. I enjoy cutting people. I enjoy cutting flesh and see blood. But if you think about it, it's very traumatic. And sometimes it is necessary, and it's the only way to give a better chance to the patient to survive. But it's not going to be the only one. And you need to start opening your minds to all sorts of things that we didn't think in the past were possible. Microcirculation is a bunch of stuff, dynamic organized chaos. At the same time, there are empty and filled capillaries, and there are moved but flux motion. So it's almost like a Star Trek, you know, flux motion, the flux capacitor or something like that. So it is something that we think about it. And this is regulated by different concepts: metabolic, physical, humoral, and nervous. And this has been on the board since 1970 in England. Stoker started seeing the relationship between the diameter of the blood vessels and the nervous stimuli. But little was known then, and little is known now, maybe a little bit more, but not as much as we are about to discover in this field that is important to you as a vascular surgeon. Why is important? Because if you don't understand microcirculation, it doesn't matter if you do a bypass, fem distal bypass in 1 hour and 45 minutes with excellent flow, if the blood is not perfusing. So what do you do that? That is what is make you differentiate you between butchers, barbers, and doctors. It's not going to help a septic patient do that kind of surgery when the capillaries are shut down because the sepsis is just killing the patient. See what I'm saying? So that's what is going to make you look different and help your patients better. So the arterial venous system has pressures and sizes. So when we go to the medium and small vessels that are already too small, we are talking about 50 to 100 micron. So obviously not visible to the human eye. These are the vessels that are going to give the resistance. And the small are the micro. The micro, 5 microns, are just the arterioles that are going to feed into the capillaries. In the same way, the vein side manages pressures and sizes that are going to return the blood to the heart, lungs, and kidney to get rid of this bad stuff and bring good stuff. So in the capillaries, all these 5 microns arterioles are going to perfuse between 15 and 20 capillaries. These have a single endothelial layer opposed to a basement membrane, and the permeability is going to be something that you're going to study a lot in some places. I don't know where you guys are training, but some of them favor more than others the study and understanding of this area. But all this flow through the capillaries is regulated by arterial and myogenic response, the veno-arterial reflex, precapillary arterial vasomotion. I'm going to concentrate on the precapillary arterial vasomotion because there are some advances that we are having that are remarkable in this area. Not because the other ones are not important, but because it's where we have learned the most so far. So the arterial vasomotion is going to be controlled by nitric oxide, which you know was called the molecule of the century, last century, and basically with vasodilatation, but also by the endothelium-derived hyperpolarizing factor. That is the best I can understand this is the control of potassium ions in the interstitial space that are going to vasodilate and relax the muscle in the endothelium, causing vasodilatation and increased perfusion in certain areas and closing others where there is no EDHF or nitric oxide. It's how the capillaries open or close, depending on this. And this vasomotion, lack of better description, is like this peristaltic movement that the capillary has that is initiated in the arterial side and travels through the capillary all the way to the vein, and is what is going to perfuse these all the nutrients into the cells. It's life. That's what life happens. It's not in the knife. And again, I love cutting on people, but you need to think beyond that. So the important thing about this that I found is the amplitude of the vasomotion is 1 to 10 hertz. Well, there is a company in Germany called Beamer that we are doing protocols with, along with NASA, that have the ownership of this electromagnetic pulse that matches exactly this frequency. Nobody else can do it but them. So treatment with this pulse electromagnetic field has been proven that increases the vasomotion on the capillaries by releasing nitric oxide. So if we have not discovered but figure how to release nitric oxide by vasomotion in the capillaries, this is going to be groundbreaking. So it is important understanding this kind of problems in our patients. That's why capillaries are open, capillaries are closed. What chooses what is a mystery, how, or seems to be a mystery why some capillaries close, what others open in certain areas, and what is the reason. It might be related all to vasomotion so far. So all these mechanisms have different changes in different diseases. I'm going to just talk about two briefly. Diabetes, selectively, nobody knows why, it targets the retina, renal cortex, and peripheral nerve. Those are the symptoms that normally we see in advanced diabetes, you know, in all our patients. But what happens is going to destroy the glycocalyx, and the arterial vasomotion is blunted. That's important. Might be related to nitric oxide or EDFHA. So we need to think about that. Sepsis, same thing. I'm not going to go over all those points. It's just for you to see how deep, how beyond, you know, just bacteria and fever and hypotension and everything is molecular level that you need to start thinking about. So what happens? Well, again, the vasomotion, let's see, I paste it here, decreased nitric oxide production. So there you go. Arterial myogenic response is blunted as well, and the glycocalyx is damaged as well. So this goes back to physiology. And now, I'm going to ask here, now, you guys just finished med school, is that right? Or I mean, right, or no? Okay, so. Who knows what this is? The Starling principle. Nobody? The perfusion of the capillaries, the pressure, hydrostatic, osmotic, goes out, comes, right? Is what you learn, right? Yes or no? Come on, wake up. Yes. Okay. It's not true. And it's amazing how you guys haven't, how the med school is still teaching this. And this is another way, this is another issue why you don't pass Keynote into Windows, into PowerPoint. Look at that. That was perfect on Keynote. Anyway, so it's not true. I'm telling you, I never did any research of this. So Starling is the one that figured that the equilibrium at the capillary level was due to two forces. The hydrostatic pressure, right? The blood comes with certain pressure into the capillary that exceeds the oncotic or colloid osmotic pressure that keeps the fluid inside the capillary, and there is perfusion. There is perfusion leaving the capillary right here. And the net pressure is out. Therefore, there is fluid leaving the capillary. But then the hydrostatic pressure decreases, the oncotic pressure is the same, and the fluid is reabsorbed, and just leaving about a small amount for the lymphatics to pick and retrieve to the circulation via the thoracic duct. But whoever reads the way I had to Starling's paper is just assumption. He never said anything, but like in everything in medicine, something sounds just this reasonable and you run with it. And that's it. You know, you found the Holy Grail. You know, this is what it is. He said it. This is assumption. I don't have the tools to completely calculate this. So it wasn't until more than, 100 plus years later that Danieli, and we'll go there in a minute, you'll understand the point, observed for the first time this hydro-like gel layer inside the endothelium that he called glycocalyx. Well, not he, but somebody later did that. And this structure has several functions. And that is very important in the function, in the Starling's principle. You see that in a minute. The basic structure is we have the endothelial cells with the pores here. We have proteoglycans, syndicans that go across the membrane. We have glypicans, another set of proteoglycans that cross the membrane. They are firmly attached, and then 90% of them they have heparan sulfate in the end. That is a natural anticoagulant. Then we have glycoproteins selecting EMP, integrins, and immunoglobulins. So that's my wrong spell there. And then we have heparan sulfate linking the glycocalyx. This is in a skeleton, it's in a structure that what is going to happen is going to trap fluid here. Now, the thickness is between 500 and 2,000 nanometers, and the total surface in the body is 4,000 to 7,000 square meters. That equals, for somebody that doesn't have that much concept for metric system, about 0.9 and 1.7 acres of glycocalyx in the human body that is trapping fluid. You'll see that what is important. This is negative charge and has rheologic and microenvironmental functions. I went backwards again, sorry. So, the glycocalyx, as you can see, is this hair-like area in the endothelium. And what was discovered, we're not going to go, this is not the purpose of the talk that deep, that the equilibrium that we thought was between the intravascular space and the extravascular space, it doesn't exist. The equilibrium is between the intravascular space and the subglycocalyx space. So, when you give Lasix to a patient with edema, what happens? Improves the first day, the first 2 days, the first week, and then they stop working, and the doctor just doubled the dose. Typical. It's not drawing fluid from the interstitial space. It's drawing fluid from the glycocalyx. It's dehydrating the glycocalyx. Patients in the ICU, it's not done anymore, but when I was a resident and a fellow, we used to do the famous Lasix sandwiches. We used to give albumin to the patient to draw fluid from pulmonary edema, and then give Lasix to get rid of the fluid. It's easy, right? Never work. I wonder why. So this is important to understand because this glycocalyx, if we have this cartoon here, you know, symbolizing the plasma and the fluid that is intravascularly, what is going to happen is going to be absorbed or by the glycocalyx. So when you are dehydrating, when you heap diuretics, you really are dehydrating the glycocalyx, which can have 1 to 1.5 liters of fluid. That's a lot of water in the body trapped in that structure. There is a lot to learn about this, way more, and you guys need to sit down and read this, because as you become advanced in your vascular careers and you're taking care of patients in ICU, well, I mean, I really don't know what the integrated program does now, but when we used to do 5 years of surgery, and 4th and 5th year we used to run the ICU. You need to know how to manage this. So in 2004, Adamson, Levick, and Michel revised the Starling principle, and guess what? There is no reabsorption in the capillary, 0. Somebody ran with the idea, looked nice and cute, and ran and stamped it in every single book, and it's been there for 100+ years. There is no reabsorption. All the fluid that leaves through the capillary doesn't go back in the venule, none. Except, well, there are some exceptions, like always, lymph nodes, kidney, intestinal mucosa, that's it. So suddenly, out of the blue, the lymphatics are very important, because all that fluid needs to come back somewhere. And that somewhere, here are the lymphatics. So that's when the lymphatics become really, really important, and people start paying more attention to it. So the structure that we saw earlier, we have the arteriole and the capillaries and the venule with those respective sizes. And then we're going to find a single endothelial cell layer of cells in the interstitium that are going to have collagen fibers around, and they are going to have anchoring filaments attached to these cells that they are mobile. They are not completely fixated in the interstitium. Then these are going to widen the layers of cells, and they are going to increase the diameter. And at some point, some of those cells are going to be hypertrophic, and they are going to form valves. The valves in the lymphatics are not the same the valves in the veins that are fully formed structure. These are just cells opposite to each other that are going to be one-way valves. And they're going to develop a basal membrane, and then pericyte. These pericytes are early muscle cells that are going to have the capability of contraction. And that is going to be the collecting lymphatic. This is the basic anatomy of the lymphatic. Now, how does it work? This wonderful production was done by me, so be patient. The blood comes through the capillary, there's perfusion, and then that ultrafiltrate, what is going to happen is going to expand and again, doesn't loop, anyway. So it's going to extend the collagen fibers, and is going to pull the anchoring filaments, opening the cells that act like valves, and fluid is trapped into the lymphatics. It's how lymph comes to be. The obvious question is, what is the difference between edema and lymphedema? It's the same fluid, isn't it? From the get-go, well, it is and it's not, like always. So when we have it, and we'll go there in a minute, when we have this gradient 0 that doesn't exist, there is no motion, there is no flow in the lymphatics, then with flow as minimum as 0.2 and 12 centimeters of water, these are distended, and then lymphatic fluid is trapped into the lymphatics. When we have an obstruction for whatever type in the venous side, DVT, CHF, renal failure, whatever is going to increase the ultrafiltrate in the capillaries, the lymphatic is going to try to accommodate this extra fluid, but it's not going to be able, and it's going to be a high hypodynamic failure, edema. Edema is a symptom, okay? That's first thing. Now, when we have patients that have radiation therapy and the lymphatics are damaged, then the ultrafiltrate is normal, but the lymphatics are not able to manage, and that is called low output or mechanical failure lymphedema. Lymphedema is a disease. Edema is a symptom. And these curves show the same thing. When we have increase in the lymphatic and the fluid load, the lymphatic transport capacity increases, but reaches a point that is not capable anymore, and then fluid accumulates. On the contrary, when the fluid load is the same, but there is a damage of the lymphatics, then we are going to have lymphedema. Is that clear? It's not that difficult, but you'll be surprised how many people, what? So You need to know this. So these are facts that have no specific place. You know, you find all these cool facts. Where do I put them? I don't know. Well, throw a slide there that says with no specific place, right? So it is important to understand that in a patient with thoracic duct injury, that fistula is going to produce close to 4 liters of fluid in 24 hours. That's a huge amount. That tells you how much fluid the lymphatics are managing. But if we know that the lymphatic nodes absorb average 50% of that fluid, they're going to concentrate the lymph by 50%, then that'll give us an 8 liters a day. That's a tremendous amount of fluid. The lymphatic system is very important. If we know that the plasma volume in average is about 3 liters, then we are going to have a turnover every 9 hours. And just as another fact that have no specific place in this lecture, in acute hemorrhage, and you can move about half a liter into the intravascular space from the glycocalyx in 15 to 30 minutes. So, and that's it for that. Questions?